Dr. Christopher Biggs. Dr. Christopher Biggs specializes in radiation oncology and is an expert in radiosurgery and urological oncology. Dr. Biggs co-founded Arizona Center for Cancer Care in 2008 with Drs. Daniel Reed and Terry Lee. He attended the University of Arizona, where he received his Bachelor of Science degree in molecular and cellular biology. Dr. Biggs earned his doctorate in philosophy from the University of Southern California and his medical degree at Stanford. For 5 years, Dr. Biggs performed radiosurgery at Barrow Neurological Institute and also served as director of the Baptist Oncology Center. Dr. Christopher Biggs. Dr. Shawn Blick. Dr. Shawn D. Blick specializes in urology and joined Arizona Center for Cancer Care in 2010 when Valley Urologic Associates, which he founded, entered into a partnership with them. He earned his Bachelor of Science degree in nutritional biochemistry from Cornell University and attended medical school at Mount Sinai School of Medicine. Dr. Blick's residency required him to complete 6 months of oncology training at Memorial Sloan Kettering Cancer Center in New York. As a urologist in private practice, Dr. Blick has specialized in men's health, erectile dysfunction, male incontinence, Peyronie's disease, BPH or enlarged prostate, and prostate cancer. Academically, Dr. Blick has taught multiple courses on advanced techniques for penile prosthesis insertion, artificial urinary sphincters, and male slings. Dr. Shawn Blick. All right, gentlemen, thank you so much for joining us tonight. A very important forum that we're going to moderate about prostate cancer, get into all the modalities and treatments, myths, and actual truth about the disease. But before we do, how about letting our audience know what motivated you to get in this particular discipline of medicine?
When you choose something as a career, for me, it was important to choose something challenging. And when you look at what cancer does to people, it is the most challenging singular moment of their lives. It involves everything from, of course, their health and whether they might or might not live. It involves all of their family members and social connections. It has amazing financial impacts on them. It impacts their lives in so many ways. And so to be able to be part of the process of helping someone through that, for me, was just, it's impactful, it's meaningful, and that's why I like doing it.
Great reason.
Yeah.
Dr. Blick?
Well, as you know, I'm a urologist, and so I do other things besides just oncology. But I think I was attracted to urology, at least partly because of the people who were in it. There were a lot of happy people. There was a lot of happy medicine, meaning we were having great impact on people's lives and in a very upwards, kind of a positive kind of way. I was very attracted to the unique technologies that urologists do. We have a large array of different technologies, from open surgery to microsurgery to robotic surgery to endoscopic, telescopic surgery.
Wow.
All this stuff is there. So it together, I think that brought it together and made it a specialty that I wanted to pursue.
Let's stay with you for a moment. Let's talk about prostate cancer specifically, but let's talk about the gland in a man physiologically, what its function is.
So the prostate is actually a small gland that is located between your bladder and your penis, and you must pee through it in order for urine to come out. The function of the prostate is actually to provide nutrients for the sperm in order to allow it to better fertilize an egg. It also provides an enzyme. You might have heard of PSA.
Yes.
It's an enzyme that liquefies sperm and also facilitates like it's a conduit for the sperm to fertilize an egg. Short of that, it is just a big nuisance.
So to follow that up, Dr. Biggs, so now that particular gland gets compromised. What does that look like when it presents to you in an office setting? What are the markers that you look at to determine that that's happening?
I'm at the end of the food chain when it comes to prostate cancer, and that means that, you know, my colleague here has probably seen a man with an elevated PSA and done a biopsy on him under ultrasound or MRI guidance. And then pathologist has looked at that sample and told us, this is prostate cancer. So by the time men come to me, they've been worked up pretty nicely. And so I get the whole picture. I get to read the book of their prostate cancer life up to that point, if you will. And really, it's my job at first to sit down with the man and usually his family and say, well, this is what this means. So we have all these really interesting results. Now it's time to go through them and kind of interpret it, if you will. And the two major things that we see are what are called the Gleason Score and the PSA. So the Gleason Score is when the pathologist looks at the cells under a microscope. And there's an old pathologist named Gleason, and he's in his 90s now. I think he may still be with us. Very famous guy, and he wanted to kind of make the grading of prostate cancer biopsies, he wanted to standardize it. And so he would give a score from 1 to 5. 1 being a cell that might be kind of maybe growing a little too fast, kind of maybe taking up a little too much space. Not normal, but definitely a cancer, but low grade. And then you can move on up the ladder and you can think about cells that might be chewing on their neighbors, if you will, or kind of wiggling into blood vessels or breaking down the boundaries that keep it together. And you can see that under the microscope very, very clearly. And there are specific criteria, and so you can get all the way from a 1 to a 5. But what we've really seen over the years is that 1s and 2s have dropped off. I call it grade inflation. So pathologists really mostly now will only give a 3, 4, or 5. And if you see a prostate cancer, they sometimes will see two populations. So they'll see something that's a little bit low grade, like a 3, and they might see something that's a little bit higher grade, like a 4. And so Gleason wanted to account for that. So he said, hey, let's put the most common thing we see together with the second most common thing we see and add them together. And maybe that will be significant. And it turns out to be significant. And so if you have a Gleason 3 plus 3 equals 6, that's really the lowest modern score that we see for the most part. And then a 3 plus 4, you can get a 4 plus 3. If you only see one type, you just kind of add the score to itself for internal consistency. So you can get a Gleason 4 plus 4 for an 8, all the way up to a 5 plus 5 for a 10. And I saw a patient like that just last week.
Wow. Dr. Blick, if you could just define PSA for the audience, because we toss that acronym around a lot in public, and those of us who are lay people, we don't necessarily know what it means. Prostate something antigen, right? Or
Pretty good.
I forgot the S part. But what does it really define, and is it really a good barometer if it's not combined with, like Dr. Biggs said, the Gleason score? Is it on its own as a standalone number an indicator that you need more investigative work?
So PSA stands for prostate-specific antigen. It's produced by the prostate and expressed into the blood. The larger the prostate, the higher the PSA. So the big challenge is that a large prostate can express a large PSA and be confused, let's just say, with prostate cancer. It's hard to discern. So when a PSA gets to be at a certain level, it starts to create a risk for prostate cancer, and we need to do a biopsy in order to decide whether it's cancer or just benign enlarged prostate. The problem is that you can get prostate cancer at any PSA. So by itself, PSA alone is not the ultimate determinant. We do still have to do digital rectal exams at times to be able to define if someone has a prostate cancer, for example, a lump or a nodule. So when we're doing exams on the prostate, we're really looking to see if there's a nodule, an irregularity, a hard spot that might suggest a prostate cancer at any PSA. For example, I once had a 42-year-old male with a PSA of 0.9, which is very, very low. But on physical exam, he had a very hard, rock-solid prostate. And as Dr. Biggs just alluded to, he had a Gleason 9 prostate cancer, very aggressive. And so we were able to act early and cure his prostate cancer because of that unique finding. It's also other things that confound PSA. PSA can be elevated when there's infection. PSA can be elevated when there's instrumentation, such as cystoscopy. And it can also be affected by low testosterone, which people aren't aware of. So imagine you had low testosterone. PSA no longer is well expressed anymore. So what happens is that you could have I get a low PSA, but still have a much higher rate of prostate cancer in that low PSA range if you're low in testosterone, and we don't always check that. So there are variables at hand that make it a little more confusing, and I guess it takes a little bit of expertise and knowledge to tease through it and decide who should be biopsied, who should be watched.
And it's detective work, and your body of work and the cases you've seen help you in ascertaining for these types of cases that you said that don't present immediately.
The most important part is that I think prostate cancer screening is really important. I really do. There's always been a controversy over it. It's probably beyond the scope of this discussion to go into the real intricacies of the controversies of screening. But most urologists, and I'd probably fair to say radiation oncologists, would say that screening reduces the mortality of the population we screen, and therefore early detection usually translates into better survival. And because today we do not treat all prostate cancers, we do watch very low-grade, low-volume disease. So some men are just being followed. We can mitigate the risks of biopsy and mitigate the risks, I should say, of screening, I should say. So I think it's a risk-benefit ratio that is worth taking, and that's my answer to that.
Well, and here's a question for both of you, because as men, we're not typically as open with our emotions as women are. And I have a wife and 2 daughters, so I can speak from experience, not in a bad way, it's just a different way. So we express our emotions and typically maybe close up a little bit. From your purview as professionals, how difficult is it to try and communicate or get the individual to communicate with you, like you said, from a standpoint of early detection, but also articulating to you maybe comorbidities, other things that are going on in their life that may exacerbate what's going on?
The prostate is in a very tender spot. And it's really, we do identify as men with that spot as being, kind of central to our male fertility and our sexual prowess, if you will. And it really does stir up fears that you're not going to potentially be able to have sex if this is what's going to happen to you, or are you going to be able to be romantic, down the line. And so a big part of the discussion in prostate cancer is what's going to happen and what is the likelihood of hurting those ego moments, if you will. Once you kind of get in a room with a man and he's gotten over the kind of shock, and I think, there's a little bit of despair being diagnosed with this, then it's time to kind of take a deep breath. Let's let our heart rate go down, reduce our blood pressure a little bit, and learn about it and listen to each other. And it's very important for us to listen to the man as much as our patients, just as important for them to learn from us. So, but once you get in there and the diagnosis has been established, most men are very open and honest, about what their desires and wishes are. Because
they see you're an advocate for them. Information is power, to kind of, like you said, demystify that fear. Right. It doesn't mean X. Let's try to ascertain. So do you guys work in tandem with one another from the standpoint of once the disease has been evaluated, you determine a game plan? And if so, what are the different modalities that are available? And I'm sure it's all contingent on how invasive the disease is at the time.
Well, I would say, as a urologist, we like you mentioned before, we're the front line, and we'll often diagnose the cancer and find ourselves presenting a variety of options. And then based on certain characteristics, let's just say of the cancer of the patient, the value system of the patient, I will then ultimately make a recommendation, let's say to have the patient see Dr. Biggs in consultation. There are times where more than one answer is appropriate. It's not always so clear. And so we may have the patient see a uro-oncologist in our group, someone who specializes in cancer urology in our group, who does, let's say, a high-volume robotic prostatectomy, and have an opportunity to meet with that person and meet with Dr. Biggs, for example, and make a decision at the end. When anyone gets informed consent about a treatment, there's a medical bias. What we really think at heart is what's best, and then there's the value system of the patient and what they're willing to accept. And there needs to be a meeting of minds in that in order for someone to move forwards.
Well, let's go out to the audience and ask some questions. Who would like to ask the doctors a question tonight?
Okay, thank you. I've known, unfortunately, several people with prostate cancer, including my dad, and including very intimately one of the guys I dated. In both cases, the side effects were horrific. Afterward, there was incontinence, there was erectile dysfunction. Fortunately, these were a while ago. Are those getting better? Are the side effects and the consequences getting better?
First of all, without any question, every single prostate cancer option or treatment has a risk for erectile dysfunction or urinary incontinence. But there's differences between the treatments and what the prevalence of those side effects are. That being said, I think we're all getting better and better at what we do. Surgeons who do robotic prostatectomies, the invention of robotic prostatectomy has minimized or decreased erectile dysfunction and has brought urinary incontinence down, but is by no means 0%. I know Dr. Biggs can speak better for radiation, but I refer a lot of patients to him, and the patients that are treated by him do extremely well. Today's radiation, from a urology perspective, do awesome. The incidence of erectile dysfunction is probably far lower than that of surgery, and I would argue that the incidence of incontinence after radiation approaches 0% today. So there are differences. Surgery has gotten better, radiation has gotten better, but I think there's probably a much better profile in the radiation world than there is in the surgical world, just by the nature of the procedures. Yeah. That being said, there are solutions. I mean, we'll talk about them separately. Okay. Dr. Biggs, do you want to comment a little? Or?
Yeah, I do tell people, especially if they have a family member or friend who got radiation in the olden days. That's what my daughter calls it, the olden days. And I said, well, this is not your grandma's radiation. This really is totally different. And right at the turn of the century, we started getting a new technology called intensity modulation for radiation. And what it really was a marriage between the ability to image the prostate with a CT scan during the treatment, together with the computer being able to control the radiation with these fine little leaves, so that today what it really looks like is 3D printing of radiation into the prostate. So yeah, by and large, if you're continent before you start radiation, you'll be continent after. That was not always the case. And if you have a good potency score beforehand, your likelihood of being potent after is very high, 80–90%. So things are much better than they used to be. And I see the results of Dr. Blick's work as well. They have really improved as well.
That's great. Thank you.
Thank you, Judy. Great question. Lauren, go ahead.
Hi. I've always been told that if you do have prostate cancer, then that's the one you want, so to speak, because it's the least aggressive and the easiest to cure and the slowest to grow. Do you agree?
Well, that the initial discussion of the Gleason score really plays into the answer to that question, because we definitely have men who have a low PSA and a normal testosterone, which should be checked, and a Gleason 6 cancer, and they can very safely be watched very carefully. We used to call it watchful waiting. Now we call it active surveillance. I like that better. It's like SEAL Team 6 is watching your prostate. And it involves a little bit more elaborate kind of protocol for watching and making sure that the patient themselves stays safe, because you don't want a runaway prostate cancer that you're not watching carefully. But in the case of high-grade prostate cancers, they are truly dangerous, and a lot of men die of prostate cancer. In fact, it's the #1 killer of men with cancer in the country. So while we have this, there are mixed messages with prostate cancer. On the one hand, yeah, if you get one of these slower growing prostate cancers, you could watch it potentially very carefully, but it is a major killer of men in the country.
Yeah.
Michael?
I was just diagnosed last Thursday with prostate cancer. I just recently changed physicians, and he decided, ask if I wanted to have a physical. Sure, I'll take one. I hadn't had a physical for 5 or 10 years, so I said, sure, why not? And sure enough, my PSA came back 4.8. So he thought, you probably should see a urologist. So I did, and had the biopsy. which was not my friend. They're not anybody's, but they found 3 spots of cancer. My question is, if I hadn't had a physical for 5 or 10 years, could I have had cancer before? I never had any symptoms. I still do not have any symptoms of, that you read about, getting up 10 times a night to pee, dripping, all the symptoms. I'm sure everybody's read about it. Could I have had it 5 or 10 years and now I'm just finding out? Or, I don't know, I'm asking.
I'd say very likely you probably did have it. Prostate cancer is, like everyone said, very slow, generally, and indolent, silent, and it usually has no symptoms. So the majority of the way, I'd say approximately 80% of the time, we're finding your prostate cancer just by PSA alone without symptoms. With that being said, probably if you had been engaging the healthcare system earlier, there's a chance that maybe you may have found an elevated PSA or possibly a slight nodularity on your prostate that might have created a trigger for you to enter the system and maybe get that biopsy earlier. There's no way to say that for sure. But biologically, you most likely had it, and it just was silent and quiet, and by chance, good chance, that you got your PSA checked and a biopsy shows it, and you've caught it, just so you know, you've caught it very early. Your PSA of 4.8 is low, and if you told us more about the nature of your cancer, we'd probably give you even more information. But the good news is that as long as it wasn't an extremely high grade, I always tell patients not to panic, relax, and there are options and very good chance that we're going to be able to help you, in fact, cure you.
Is prostate cancer hereditary?
There's not a specific gene. When we talk about hereditary cancers these days, there are a couple famous ones, in particular in breast cancer, BRCA1 and BRCA2, and they also give you a risk of ovarian cancer. In prostate cancer, there's not one particular gene that you could check for. But what we have noticed is that it does run in families. So if you have more than one first-degree family member with prostate cancer, a dad or a brother, then your likelihood of getting prostate cancer goes up significantly.
I just wanted to thank Dr. Blick. He came to our US2 support group a couple of months ago and spoke on several different subjects. I was just curious if the doctors would just speak to the benefits of maybe newly diagnosed men seeking out a support group or getting some education through that, maybe even overcoming some of that initial fear during diagnosis.
Yeah, there's nothing, you got to give credit to what you guys do. Obviously when you create a group and you become part of something, you have an outlet for asking questions, you feel like you're not alone. Your group is so well done because you guys analyze the literature, you bring in guest lecturers of the highest quality, you create a portal for information, and you create a group dynamic that allows people to relax, and like you just mentioned, it reduces their fear and gives them some confidence that they are on a good track, help relieve anxiety. So I guess I speak to give you credit for what you guys do, and I would encourage any man that gets a new diagnosis of prostate cancer to embrace this, because it'll just add information, reduce anxiety, create support. Overall, just create support.
Do you doctors mind speaking about some of the innovations in androgen deprivation therapy, ADT? Because I know there's been a lot of advances there. Thank you.
Sure. I think what Steve is asking a little bit about is advanced prostate cancer that Dr. Biggs alluded to earlier. We used to only have what we call gonadotropin-releasing hormone agonists. That's just a lot of big words for, I guess you have to understand the physiology, but it's a mechanism for shutting off the testosterone in the body. And eventually, over time, what happens is the body becomes resistant, and the cells begin to grow independent of the fact that the testosterone has been shut off in the body. Because what I'm also trying to say is that, just as a principle, that prostate cancer is at least partly testosterone sensitive. So if we shut it off with a medicine like Lupron, for example, we bring the PSA down and we put the prostate cancer to sleep. But over time, as I mentioned, it will become resistant. And so now we have this whole area of advanced prostate cancer that has exploded, where there's a whole bunch of new medicines in that area. Particularly, for example, You have to look at the space that the patient is in and what part of their disease journey they're in to decide what medicine will work best for them and what's appropriate. So for example, someone's been on Lupron or a medicine that shuts your testosterone off for a long time and now it stops working. If they're castrate resistant, but they're not metastatic, they're not necessarily spread through the whole body, there's a brand new medicine called apalutamide or Erleada, for example. As things go on, it becomes more metastatic, and we can add something like Xtandi or enzalutamide. All these things are improving survival on the order of like 1 to 2 years. Substantial, major breakthroughs. There's another one like Xtandi that's called Zytiga. Okay, so for example, and then there's chemotherapies when those things fail that move on, such as like docetaxel, or if that fails, Jevtana, for example. There's just a variety. What I'm showing you is that there's all these new medicines in this space that are relatively newer, that add survival when the initial therapies fail.
Yeah, the whole story of these testosterone inhibitors is well, it's for me one of the most fascinating things. But probably you would get bored after a while. But prostate cancer cells need testosterone to survive because in their nucleus, in the DNA in there, testosterone binds to a protein that tells the DNA in a certain spot, go live and be happy and proliferate and go wherever you like. So mostly just proliferate. And so what the Leuprolide or the Lupron does is it turns off testosterone production in the testes, which is where most of it's made. Well, these cancer cells start getting really clever. And what they do, for example, is they start making their own testosterone inside the cell itself. So now they don't need it from outside. They're able to make their own. So you say, okay, well, we can take care of that. We're going to give you a medicine that blocks the synthesis of testosterone so that no matter where it's made, it gets blocked. Oh, well, that lasts a couple years. Well, men are living 2 more years because of that medication. And then you can give a medication that binds to that protein that goes to the DNA and blocks the testosterone from binding to it. And then the cells say, hey, you know what, that protein, I'm going to snip it. And it's going to be able to bind to the DNA even without testosterone. And so the cleverness of cancer cells to escape our different kinds of therapies is a little too scarily good. But these different medications are attacking it from these really fascinating and interesting biochemical frameworks, and they're making men live 5, 8, 10 years longer than they would have otherwise.
Dr. Biggs has his degree in cellular biology, PhD in cellular biology, as you could tell. So it's pretty awesome.
How about a big hand for these guys? What a wonderful story. Any final comments before we sign off tonight, just in summation? It seems to me, just as a neophyte and somebody who's just a regular guy, that there's a lot of innovations in your clinical modalities, that you're on the cutting edge. You're both very passionate. Your whole group is about, conquering this disease at some point. Give us your final thoughts as we close off this show.
For me, I think, it's, first of all, there's great new technology. I think prostate cancer patients are surviving longer than they ever have, and we're doing better than that. And now there's a whole new space of prostate cancer survivorship and what to do about their quality of life. And my expertise is in handling people's issues with their quality of life. What I mean by that is their erectile dysfunction or their urinary incontinence or any voiding dysfunction for that matter. And so my expertise is in prosthetic urology. I help men who have erectile dysfunction that does not respond to conservative measures, and we can do things like penile implants. There's a lot of misinformation about it, and I just like to let people know that it's an awesome solution that people should at least take a look at, because we have great results, we have very high success, and we can also help people with their urinary incontinence today. When they're done with surgery, particularly, maybe less so with radiation, but still any therapy can cause it. People will leak urine, and it has a profound effect on their quality of life, and today we can fix that with wonderful, minimally invasive surgical solutions that are very highly effective, minimally invasive, and people should be aware of those. They shouldn't wait 10 years to find out that this solution exists. So that's my expertise. That's my summary message that I'd like people to take home.
I guess what I would do is I would speak to you. You just got this diagnosis. And so it's what I try to tell most of my patients is, okay, your life just changed, and you'll remember that moment forever. But take a deep breath. You're going to be around a while, okay? Many, many years, actually. So at this point, you're going to go on a roller coaster ride. And the roller coaster is going to be bad news, good news, bad news, good news. Bad news is you got prostate cancer. Good news is we can cure it. Bad news is it might have some side effects. Good news is you got a bunch of choices. Bad news is it's going to be really hard to decide because you got all these doctors with all their different, modalities that they want to kind of share with you. But mostly it's going to be good news because what we have tried to do over the past few years in particular is take men with what is really an excellent prognosis and make their experience not as traumatic as it used to be, and to spare their body the side effects of the radiation. And what we really want to do is have you look back 6 months from now, a year from now, and say, hey, I'm the same as I was a year ago, but I don't have the prostate cancer anymore. That is like the golden moment that we have if we can achieve that goal. And not everybody gets there, but a lot more every year as we advance with the precision of these treatments. A lot more men are doing better and better with their quality of life going forward. So I would say have hope. Don't try to take a deep breath. Try not to lose too much sleep. You're going to do great, but you got a little bit of a process ahead of you.
Dr. Biggs, Dr. Blick, thank you so much
Thank you.
for all your expertise.
Thank you.
It was very enlightening. We really appreciate your comments. And it's a big topic, and I think we covered a lot of bases on tonight's show. That'll do it for this edition of Arizona Doc Talk. For AZCCC, who brought you this prostate forum, I'm Mark Lewis. Thank you for watching.